Good morning, everyone, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Shira Doron with the New England QIN-QIO. This is the 9th and final session of the 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, which has been brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's session is Measure Your Success, Monitoring and Tracking Data. I have a few housekeeping items to review before we begin today's program. This webinar will be recorded, and the presentation will be available within a few business days on the QIN-QIO website. The phone lines have been muted for the presentation, but we do ask that you please do not put your line on hold. Also, if you just joined us as these announcements are being made, please manually mute your line either by pressing *6 on your phone or using your manual mute button. If you have a question at any point throughout the presentation, please enter it into the chat panel to the right of your screen. Please make sure to send your comments to all participants. Elisa Victor from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. You will also have an opportunity to ask questions over the phone at the end of the presentation. And now I'd like to turn it over to Melissa Cumming from the Massachusetts Department of Public Health to introduce our speakers. Melissa?
Great, thank you. Good morning, everyone, and welcome on behalf of the Massachusetts Department of Public Health. I'd like to introduce our speakers today. First, we will hear from Dr. Shira Doron. Dr. Beaulac is the pharmacist head of the Antimicrobial Stewardship program at Tufts Medical Center, as well as the infectious diseases pharmacist for the institution. We also have Dr. Shira Doron. Dr. Doron is a physician in the Division of Infectious Diseases at Tufts and has been the physician head of the Antimicrobial Stewardship program there since 2005, and she also serves as the Associate Hospital Epidemiologist. And last, we have Dr. Gabriela Andujar Vazquez, who is also a physician in the Division of Infectious Diseases at Tufts. She is part of the Tufts Medical Center Antimicrobial Stewardship team as well, and is also one of this year's CDC IDSA SHE LEAP Fellows. And with that, I will turn things over to our speakers.
Thank you, Melissa. So this is Shira Doron, and I'm going to start us off. And today we're talking about measuring your success, how to monitor and track data. And we're going to talk about that from a few different perspectives. We're going to first talk about how to apply an antibiogram. And then Kira's going to talk about comparing various methods for tracking and reporting antibiotic use. And then finally, Gabriela is going to talk about reviewing the NHSN definitions for Clostridium difficile infection, reporting methodology, and interpretation of rates. So, antibiograms. What is an antibiogram? The definition is an overall profile of antimicrobial susceptibility testing results of a specific microorganism to a battery of antimicrobial drugs. And we use aggregate data from a collection of microbiological reports. So here's an example from Tufts Medical Center. This happens to be 2015. And what you can see is this is the gram-negative portion of the Tufts Medical Center antibiogram, and it's a year's worth of data. This happens to be our inpatient antibiogram, and it includes all sources. And what you can see along the left-hand column is all of the organisms that were isolated, the gram-negative organisms that were isolated in a year with any significant frequency. And so you can see that one of the organisms, Enterobacter rhamnosus, was only isolated 19 times, and others, like E. coli, were isolated to almost 300 times. And then across the rows there, you'll see the different classes of antibiotics: penicillin, cephalosporins, aminoglycosides, fluoroquinolones. There's trimethoprim, sulforbactrim there, and nitrofurantoin specifically for UTIs. Now, for each of those antibiotics, the antibiogram will show you the percent susceptibility of that organism to that antibiotic. And in some cells, you'll see that there is not a number, either because that organism is always resistant to that antibiotic, so IR represents intrinsic resistance, or because there were no data, and that means that that antibiotic is not on the standard susceptibility panel performed by the lab for that organism. And in some cases, NA or just not appropriate. You would not expect there to be a result for that antibiotic. And so, you can take a look at this for your institution, and it can help to guide treatment, and we'll explain that in a moment. So, well, where does that data come from? So, as you know, you send a specimen to the microbiology laboratory, and it gets cultured on a plate. And then if there is a burden of bacteria in that specimen, there will be colonies that grow on that plate. The microbiology lab technicians will do two things. They'll take some of those colonies, put them on a slide, and create a gram stain to determine whether the organism is gram-positive, gram-negative, or something else. And then they'll also do a bunch of enzymatic and other types of studies. And so you can see here, this is a microscan plate, and the organisms were put into the plate both in an attempt to identify the organism, which is usually successful, and to figure out the susceptibility of that organism to antibiotics. And so you can see here the result. In this case, as an example, the organism is E. coli, and there's a list of antibiotics that E. coli is tested standardly against, and then a minimum inhibitory concentration for each antibiotic. And for each drug combination, there is a standard interpretation, either resistant, or where you see R, susceptible, where you see S, and sometimes I for intermediate. But there's a big caveat here with antibiograms, and that is garbage in, garbage out is the old adage when it comes to data and its representation. And so that is definitely true for antibiograms. Depending on what data go into the analysis, the antibiogram may not yield information that's as important as you or valid as you think it is. So some examples of things that can affect the validity and the utility of your antibiogram. Duplicate. So if you are sending multiple specimens and cultures over time on the same patient or resident, and those cultures are repeatedly positive, then your antibiogram is going to appear to have more, to be overrepresented by that organism and that resistance pattern. So for example, if you have a patient with a carbapenem-resistant E. coli UTI, and you send cultures over and over and over again, and that patient does not clear their bladder colonization. We've talked about that a lot. We've talked about the fact that we don't recommend tests of cure and repeated urine cultures on patients who don't have symptoms. If you do so, though, you will continue to see CRE after CRE after CRE, and it will be counted multiple times and make it look like your institution has a bigger CRE problem than you do have. So one of the ways around that is to limit your antibiogram testing to the first isolate or the last isolate for a given patient in a given period of time. But if you use the first isolate, you're going to underestimate resistance, because in patients who do have recurrent or persistent infections, often what you do see is development of resistance over time with treatment. If you choose the last isolate per patient at a given time frame, then you're going to overestimate resistance. So there's no perfect solution to that problem, but it's something to keep in mind. Small numbers. So if you have certain organisms that in a given year you only have a small number of, so in the example that I showed you from Tufts Medical Center, only 19 cases of Enterobacter orogenius, well, then obviously that data is going to be subject to more wide fluctuations, or where one resistant organism is going to look like a high percentage, which is going to skew your overall data. And sometimes that can be accounted for by increasing the time frame for your antibiogram. So depending on the size of your facility, a one-year antibiogram, like I showed for our hospital, may not be appropriate because the numbers in all of the cells may simply be too low. And you may want to look at two-year antibiograms or rolling two-year antibiograms. So you may want to look at an antibiogram annually that includes information from 2 years, for example. Now, the antibiograms have no accounting for your census, and so you may have many ESBLs, for example, 1 year, more than the year before, and you may be tempted to think that means that you have a problem, but perhaps it's because you have 1.5 times as many residents 1 year as you did the year before, and it doesn't actually represent a problem. As we've mentioned many times, it is impossible to tell the difference between colonization and infection just by looking at the laboratory test alone. And so when the laboratory that you are affiliated with creates an antibiogram for you, it is going to represent a combination of cultures that represent colonization and cultures that represent infection. And so an antibiogram should not be interpreted as representing the spectrum of infections that you've seen in your facility, but infections plus colonization where cultures may have been sent without evidence of infection. I mentioned that an organism can be classified as susceptible, resistant, or intermediate, and depending on how many intermediate specimens you have and how you classify that in your antibiogram, which typically just represents the percent susceptibility, then that could change how you interpret your antibiogram. Another thing to keep in mind is that you're just looking at each bug-drug combination. So you can't see from an antibiogram, or at least the standard type that I showed you a minute ago, multiple. So for example, you might be able to see that an organism is cephalosporin resistant, but you won't be able to tell how many organisms you have that are cephalosporin, fluoroquinolone, and Bactrim resistant at the same time. That's not something an antibiogram can tell you. When you use your antibiogram to assess changes in resistance patterns over time, and if you were to use them to either identify a problem or pat yourself on the back for improving your resistance pattern, you need to take into account all of the things that affect resistance patterns besides stewardship. So you may be tempted to say, oh, look, we've had a decrease in fluoroquinolone resistance because we've been doing better with our fluoroquinolone use. And that may very well be true, and you can look at both your antibiogram and your antibiotic usage data to determine that. But remember that your resistance patterns are also going to be influenced by your referral base. So where are you getting residents from this year as compared to last year, for example, and might they have a fluoroquinolone resistance problem? By your infection prevention activities and how well you're doing with things like hand hygiene, contact precautions, and environmental disinfection. Sometimes you simply see regression to the mean or spontaneous improvement, just normal fluctuation of data over time. And we can see really big changes when the CLSI, which is the organization that determines laboratory standards, changes the definitions of what is resistant and what is susceptible. And those are sometimes can show immediate and very significant differences in the frequency with which you can see resistance within your facility. So you can use your antibiogram to look at your resistance trends and to set goals for your facility. And so here's an example, again, generated from Tufts Medical Center data looking at a particular organism, Acinetobacter baumannii, a very epidemiologically significant organism, and looking at its resistance over time. And you can break it down by the various antibiotics to which it is typically susceptible. You can see that we had some issues with several antibiotics over time, and that with our antimicrobial stewardship efforts and perhaps some of our infection control efforts, we had some improvements over time as well. And then you can see that between 2013 and 2014, all but one of our antibiotics had a decrease in susceptibility, which represents an opportunity to examine our practices and examine our usage, but also, in this case, important to look at the statewide and nationwide trends, because in many cases when we do see trends like this, they represent or they reflect what's happening in a broader geographic area. Now, antibiograms are also great for determining the appropriate empiric therapy for a specific condition by taking into consideration the most likely causative organism. Here's an example of a urine culture that was done. There are sort of two ways to approach this. One is when you have a resident with a clear-cut bacterial infection for which you want to start therapy, you have no culture result yet at all, or perhaps you have only the information that your resident has greater than 100,000 colony-forming units in the urine of gram-negative rod, and they have definite signs and symptoms of a urinary tract infection. So you can look at your antibiogram and say, well, you know, it looks like the most common organism in my facility with 289 isolates in a year was E. coli. I'm going to make sure that my empiric treatment covers E. coli, or perhaps you already have the culture results growing E. coli, but you don't have susceptibility data yet. That's where the antibiogram is really, really useful. And here, looking across those columns, you can see all of the organisms against which E. coli has been tested in your institution. And so, here we see that the antibiotic that has the highest likelihood of being effective against E. coli in your institution is meropenem. Now, does that mean that all of your residents should receive meropenem as the first-line agent every time they have a gram-negative or E. coli urinary tract infection? The answer is absolutely not. And what you want to do is balance what you know about the importance of food and antibiotic use and antimicrobial stewardship concepts against what you know about susceptibility in your institution. So you can see from this that you absolutely positively wouldn't want to use ampicillin or its related oral equivalent amoxicillin for an E. coli urinary tract infection, because you'd be getting it right less than half the time. So that's probably not a good one. But you can see that there are quite a few antibiotics here where you could get a 90% or higher likelihood of being effective. If you can use nitrofurantoin, we like that antibiotic because of its lower potential for collateral damage, as we say. It doesn't have as much systemic absorption, and so there are some limitations to the use of nitrofurantoin, but it has 95% activity against E. coli and, by the way, many other organisms, and so that's a good one. In this case, you can get a success rate of 90% with the antibiotic ceftazine, 86% with ceftriaxone, and there are some oral equivalent cephalosporins that are similar to these third-generation cephalosporin antibiotics as well. So this can help to guide you in your antibiotic selection, but they are used at all when you have your susceptibility report back. Because once you have that, what you want to do is narrow the antibiotic coverage to the antibiotic, again, with the lowest level of collateral damage. The narrowest spectrum, taking into account adverse events, taking into account cost. And so here again, this organism is indeed susceptible to nitrofurantoin, which is a great option. It's susceptible to phosphomycin, although expensive, is a good option from a collateral damage standpoint. But it's susceptible it is not important to note it's not susceptible to Bactrim. And so there would, at this point, be a discussion about whether the patient could take nitrofurantoin or whether the patient, or whether the patient might need something broader. And I think that, let's see, I think Shira might be having some connection issues. Shira, when you are ready, why don't you, Shira has connection issues, so I don't know what I'm talking about. When you're ready for me to pass the ball to you, Shira, you let me know, and then we will, we'll go forward with a couple of Shira slides here while she gets her connection back. So the next section that we're going to talk about here, and Shira is going to take over when she can, is trending antibiotic use.
Sorry about that. This is Shira. I just got back in, so if you want to just pass the ball to me.
I shall.
Okay, sorry about those little IT issues, but so this is Shira Doron. I'm a pharmacist, and I'm going to talk a little bit about how to trend your antibiotic use. And I know that, what we've seen in the past is we have a lot of nursing and nursing leadership on this call, but this is an area where you're really going to want to work in collaboration with your consultant pharmacist because they can really provide you this type of information. And additionally, once you have this information in terms of being able to trend antibiotic use, they'll also help you make sense of it and be able to create meaningful goals associated with it. So there's a couple of different ways that you can trend antibiotic use. So you can, in any way that you cut this information, you're going to have a ratio, and you're going to have a numerator and a denominator because, as Shira mentioned, as census changes, you want to make sure that you're accurately describing how much antibiotics your facility is actually using. So the numerator can be various things to actually describe how much is going in. So that could be something like cost. You can look at the proportion of patients receiving antibiotics. You can look at the number of antibiotic starts. And then there's a couple of different metrics surrounding that kind of describe the course of antibiotics a little bit more detailed, like defined daily dose, days of therapy, and length of therapy. And I'm going to go a little bit more into detail about each of these different types of metrics, the utility, and some of the pitfalls. So cost is probably the easiest type of information to collect. It just overall tells you, how much are you spending on drugs and how much are you spending on antibiotics, and you can easily get this information as your cost per month from your pharmacy bills and drill down to which prescriptions are antibiotics and how much they cost your facility. The ideal way to look at this would be if you adjusted it for the volume, like the number of prescriptions that were filled, or for the number of maybe your patient census. This is, as I mentioned, really easy to collect, but unfortunately it gives you probably the least amount of actionable information because all you know is, whether you're spending within a given budget, but it doesn't actually describe how you go about that and what you need to do to improve your antibiotic spending. The next type of metric you can look at is the proportion of patients receiving antibiotics. The real benefit of this method of evaluating antibiotic use in your facility is that it doesn't require someone to be constantly looking at what's going on. It really can be done in a fashion of what we call point prevalence, of somebody picks up on a certain day and looks at,
all of the residents in your facility and what percentage of them are receiving antibiotics. And you can do that at various time points, on various days, and that way you can trend over time with averages. On average, what percentage of your patients receive antibiotics. Now, as I mentioned, that this is especially useful when you don't have the resources to have someone continuously monitoring antibiotic use or have the ability to do reporting going backwards. But this data has also got some limitations in that it won't always tell you exactly what to do with that information. It does help you potentially identify some unnecessary treatment if you have certain units or certain services that are using more antibiotics than you would expect or more antibiotics than necessary. And it can help you identify, if you're treating colonization or inappropriately using prophylaxis. And lastly, it's really convenient because it's pretty simple math. If you just look at all of the patients all the residents living in your facility at any given day, and if you're able to access med lists for all of them, just look at which ones of them are receiving antibiotics. So the example that I have here is if you have 52 patients currently in your nursing home and 13 of them are receiving antibiotics, 13 over 52 gives you a ratio of 0.25 or 25% of your patients receiving antibiotics. The next method that I want to talk about for measuring antibiotic use is probably the one that we've viewed and have worked in great length with is Antibiotic Starts. This metric is, again, it's a relatively easy way to measure antibiotic usage. It does need to be measured continuously, but you can also, if you have reporting capability, try to create a report like once a month to see how many antibiotic starts there were in that given month. This is really great for tracking success with interventions that you've made. So if you have educated your prescribers on which antibiotics are or are not appropriate, you can kind of track the number of antibiotic starts to see if those interventions were effective. Unfortunately, one of the barriers to using antibiotic starts is that it can actually make your numbers look worse if you're doing the right thing, which is taking an antibiotic timeout and de-escalation whenever possible. If you start off with a really broad spectrum antibiotic and then take an antibiotic timeout and de-escalate to a narrower spectrum antibiotic, you essentially have an extra antibiotic start because you're starting a new antibiotic. In the grand scheme of things, that's a good thing, but based on the single metric, it would actually look even worse by having additional starts. Taking that into account, that this is what we view as the most feasible metric for nursing homes to use. And it can be created to drill down to specific infections or specific providers to really drill down to create meaningful information for you to work from. Another metric that is a little bit more detailed in that it provides you a little bit more clarity about exactly how antibiotics are used is the DDD, or defined daily dose. This is developed, it was originally developed to make an estimate based off the average number of doses per day. So that way you can, it incorporates not only what antibiotics are used, how much in terms of days, but also how much in terms of grams per day or milligrams per day of various drugs. And of note, this can be used for non-antibiotics as well, like if you're trying to manage your PPI use or something like that. It can be feasible without having sophisticated IT infrastructure. It does require a little math, though, and it can be done pretty consistently over time. and just add it up. If you wanted to add all of the carbapenems together, or all of the cephalosporins together, you can just literally add things together. So it lends well to some math, but unfortunately does require a little bit of math to accomplish. We generally don't recommend pursuing this unless you have an automated method to calculate this. The other the second to antibiotic starts, the other most feasible and most informative metric is the number of days of therapy. So days of therapy is the number of days in which a single antibiotic was given. One of the challenges is that it requires patient-specific data in order for you to know who was receiving which antibiotics on which days. But with increased availability of electronic health records and improved technology, there are a lot of automated methods out there for creating this DOT or days of therapy metric. Going forward, this is considered the standard metric, and it can account for combination therapy as well. As we move towards, more global reporting, this will foreseeably be the standard metric, and currently in acute care hospitals is considered the standard metric to use. The pros of using this over antibiotic starts is that it doesn't matter what dose the patient used, and it very much it's more accurate in describing how much of the antibiotics are being used by telling you the difference between 2-day course of antibiotics versus a 2-week antibiotic course. Unfortunately, if you're doing multiple switches, it may not be or combination therapy, it may not be a clear indicator of the total duration of therapy. As I mentioned, it does require patient-level data, and it does include partial days. So if, you stop antibiotics after, 24 hours and 5 minutes, it's still going to count as 2 days worth of antibiotics. And lastly, by nature of the way, the consultant pharmacies provide antibiotics to nursing homes, usually the entire course is dispensed up front and then can be stopped early if they're maybe not appropriate anymore. It's really challenging to incorporate that into kind of cleaning up these metrics. So that's for those reasons. Currently, antibiotic starts are most commonly used by our long-term care facilities. So next, I'm going to talk very briefly about how you can normalize this information by patient days, like by your census, by the number of admissions or discharges, or you can just look at the point prevalence on any given day. So as I mentioned, patient days is probably the most accurate and will be the standard going forward of the metric to normalize to. If you're incorporating data into NHSN, they'll use the term days present, which means essentially the same thing, number of days that a resident is present at your facility. And this really is just looking at how many patients are given are at your facility on any given day for the entire month. And so you literally just add it up of, there were 10 people here on the first, and then 10 people again on the second, and then one more person came, and then there was 11, and you add it all up for the entire month. And then you can kind of normalize that to 100 patient days or 1,000 patient days, just so you're not working with tiny little fractions. You can also normalize to the number of admissions or the number of discharges, which is, again, kind of the same thing, because everyone that gets admitted gets discharged. It might not be in the same month, but it all shakes out over time. As you try to, get people up and out and kind of back into the home setting quicker, the number of patient days per admission will decrease, but your number of admissions and number of discharges probably would stay constant with that. So, and especially with your really, really, long length of stays for our more chronic care facilities, they might not be as accurate when you look at admissions or discharges when you've got a single resident who has a length of stay of 2.5 years. So in those situations, using number of patient days will give you a much more accurate look about what your census is like. And then once you've created these metrics, I just wanted to give you a few examples of what you can do with that information once you have it. So here's one example that I have from our inpatient setting of, we recognized in 2014 that we were using a lot of daptomycin, and we knew that daptomycin was a really expensive antibiotic. So we put in some initiatives to try to improve our daptomycin prescribing rates, and we did some internal benchmarking. And with ongoing effort, we saw that, there were fluctuations from month to month, but overall we were able to improve our usage overall and to really improve, try to meet our goal of reducing our daptomycin usage. We had set a threshold of 20%, and we were able to meet that goal. And then for the purposes of long-term care benchmarking, many of you have seen the emails that we've sent out with a link to submit your antibiotic use. And by doing that, it not only kind of would compel you to collect that information, but also provides you an opportunity to benchmark to facilities just like yours, so you can see where you fall compared to other nursing homes in the area. Of note, this is currently only open for Massachusetts facilities. We are primarily collecting antibiotic starts. As I mentioned, that's kind of the most feasible metric to collect at this point. And if you are consistently submitting, not only will you get your monthly information, but also we're starting to get enough information to create more aggregated quarterly reports. And as you get more and more data, it gives you a little bit more meaningful opportunities for improvement, as opposed to small numbers that are really will have big fluctuations due to maybe one or two outlier residents. So here's an example of some information that you can get fed back if you are submitting. And then additionally, what you'll get is a report that shows how your number of antibiotic starts compares to other facilities. So here you see that when you get your report back, you'll see what your antibiotic start rate is, and then how that compares to the averages across the state. And remember, these are all long-term care facilities, all nursing homes that in theory have similar acuity to your facility. So for those of you, if you have not yet started submitting, you are encouraged to do so. You can start at any time, and we hope that even after this series is done, that those that have been submitting continue to submit, and we will continue to provide you feedback about how your prescribing rates are compared to other facilities. So now I'm going to pass the ball to Gabriela, and she's going to talk to you a little bit about CDI reporting.
So another way to measure your success is also by looking at your rate of Clostridium difficile incident, right? Infections. So as you know, there is an NHSN reporting, and throughout the webinars and talking to the Massachusetts Department of Public Health, we realized that it's tricky, how to report and how to apply the definition. So we thought also explaining this in this webinar will be helpful for you to understand why, if it is important, and also it reflects on your success of your stewardship and infection control program. So the definition it's really, you have to take it very literal. There's no clinical symptoms. You just
just go by the definition as it is written. So a CDI lab ID event that you report is a C. diff positive laboratory assay obtained while a resident is receiving care in your long-term care facility and the resident has no prior C. diff positive laboratory assay collected in the previous 14 days while receiving care in the long-term care facility. So those are the cases that you report. Duplicates that are not reported because they're duplicates are any C. diff positive laboratory test from the same resident following a previous C. diff positive test within the past 2 weeks while in the facility. So basically, a positive test, you report, as long as they haven't had a positive test in your facility within 14 days prior. NHSN will further categorize this as community onset or long-term care facility onset or acute care transfer to long-term care facility onset. And this they will do by the calendar day. So community onset lab ID event is date of specimen collected less than 3 calendar days after current admission to the facility. So days 1, 2, or 3 of the admission. When it hits day 4, it's long-term care facility onset lab ID event. So if your resident has a positive stool for C. diff, on day 4, you report it. As long as they don't have a positive C. diff in your facility within 14 days. Acute care long-term care facility onset is defined as long-term care facility onset lab ID event with specimen collection date less than 4 weeks following date of late transfer from an acute care facility, hospital, long-term care acute hospital, or acute inpatient rehabilitation facility only. But the most important thing is just to apply the first slide definition, positive in your facility, no positive 14 days prior, you report it. So here's an example of how to apply the definition. Assume that this is the same stool specimen for the same resident. So your resident started having loose stools and symptoms that you're suspecting C. diff, and you sent a C. diff lab test on July 1st of 2018, and there is no prior C. diff testing in your facility, so it's not a duplicate. So what do? Do you enter this as a lab ID event in NHSN? Yes, you do. So this is an event, a CDI lab ID event, and you report it in NHSN. Now, your resident continues to have loose stools, and you sent again a stool for C. diff and testing, and on July 9th, is this a duplicate? Yes. Do you enter this as a CDI lab event? No, because this was within the 2 weeks of positive test. You had a positive test in July 1st. You sent it on July 9th. It's still within the duplicate not reportable portion of the definition. Again, you send it again on July 20th. And do you report this to NHSN? No. Again, it's within the 2 weeks of positive test because you sent one in July 9th. And as you can see, the same happens when you send it again on July 29th. It's still within the 2 weeks of positive test because you sent one on July 20th. So 9 days only has passed since the last positive test. So you do not report this. It is a duplicate. But now, you sent a stool test for C. diff on August 20th, and this is not within 2 weeks because the last lab test that for C. diff that your resident had was in July 29th, which is way more than 2 weeks ago. So this one is another incident of, is another lab ID event, and you report it to NHSN as a CDI lab ID event. So there's commonly misinterpretations of the definition, and one of the ones that we can see commonly and everywhere, not only in long-term care facilities, is that the resident had diarrhea at admission, but we didn't send it until day 4. So we think it was clearly not acquired at a facility, so we don't report it. So unfortunately, it does count, and you do have to report it because the stool was positive on day 4. As you said, as the definition I said earlier, it's considered community acquired. The lab test is positive in day 1, 2, or 3. Once it hits day 4 in your facility, it counts as yours. And there's a lot of education that has to go through about this, right? Because if your resident had diarrhea since day 1 and there's a concern for C. diff since the beginning, then earlier testing helps your CDI rate. But obviously, if the patient did not have diarrhea and had diarrhea day 4, then there's nothing you could have done. Another common scenario is that the resident developed diarrhea on day 2 of admission. He came from an acute care hospital, so it's clearly not our fault because he came from the acute care hospital. He probably developed the C. diff over there, and in day 2 just happened to develop the diarrhea and not over there. So we didn't report it. So that's not the way to apply the definition. There's no clinical judgment here to report to any consent. You just take the literal date. If it's day 4 after, you have to report it to NHSN as a CDI lab ID event, as long as the patient didn't have in your facility a positive CDI lab test within 14 days. No clinical interpretation. If the patient had that, they took away all that a couple of years ago, and now it's just strictly a positive test and the day of that positive test. So, there's also, just to remind you, I would keep this checklist to report to NHSN because most of the time these are the things that get you into trouble on how to report correctly. Always verify your facility location when you're in the website of NHSN reporting so that locations are mapped. Always review monthly reporting plan. You have to do this before you can report to NHSN. Without this, you can submit the data. Enter all C. diff lab ID events by location. Always enter denominator data for each month. If not, it will not let you report correctly. And always resolve alerts. Usually it's because there's missing denominator data. Like I said, if you don't resolve the alerts, then it won't let you report correctly. So why is it important to know or to track your CDI rate? So if your rates are higher than other facilities, it could mean a couple of things. It could mean that you're overusing antibiotics that have a lot of collateral damage to the gut and hence have more propensity to cause C. diff in your residents. So focus on the antibiotics most likely to cause C. diff and take a look at your antibiotic usage data to see why your facility is an outlier in CDI rates, if it is. Also, it helps for your infection control program to look at your cleaning protocols to see if your environmental services are doing a good job at cleaning your C. diff rooms. And sometimes it's over-testing, so that's where your diagnostic stewardship comes up. Sometimes there's inappropriate testing, like testing while on treatment, with loose tools or testing for what we should not do, which is test of cure. As we have talked in previous webinars, we do not test for curing C. diff. The patient can be positive after treatment for months to years. So over-testing can also increase your CDI rates, and to combat this, basically you need to educate a lot of your staff to not send unnecessary stool tests unless clinical symptoms of C. diff your resident has. And I think that sort of concludes our webinar today. If you have any questions, please put through the chat or unmute your line.
Hi, this is Lacey. It looks like we do have a question in chat from Linda.
Yeah. So Linda has a question about Antibiogram, and so
a question about how to use the susceptibility report versus the antibiogram itself. And so I'll just address that. So the antibiogram is really a statistical compilation of data. Let me give you another example of how you treat the resident in front of you based on their susceptibility report and not the antibiogram, but how you can use the antibiogram to help before you have the susceptibility report only. So you might have a resident who has, let's say, a pneumonia. They coughed up a sputum, and I'm going to use E. coli again. Your antibiogram may show that 98% of your E. coli are susceptible to meropenem. Meropenem, I'm using that example because it's sort of our biggest gun. It's our most broad-spectrum antibiotic. It's expensive. It contributes to resistance. And so maybe your resident is really sick, and maybe you do want to use meropenem empirically before you have your susceptibility report. But then you'll get your susceptibility report back. And you may even find that your organism is resistant to meropenem, even with a 98% susceptibility rate. But you may find that, in fact, the organism in your resident that you've sent a culture on is susceptible to Bactrim or ciprofloxacin or cefazolin, which is the equivalent IV antibiotic to Teflex. And so you may actually find that the resident in front of you is susceptible to a narrower spectrum or less expensive or an antibiotic that has less potential to promote resistance. And that's always going to be the correct approach to taking care of that resident. So the antibiogram can be a useful tool to treating individual patients and residents, but only until you know what your patient or resident actually has for an organism and what their actual susceptibility data is. Once you have that, all of that statistical data that was compiled over a year or 2 years is no longer relevant. Besides the fact that those statistics can change over time, so particularly if you're looking at statistics that were generated over a year or two, things may have changed quite a bit between when those data were generated and the residents that you're looking at today, particularly in outbreak situations where there might be multi-drug resistant organisms going around your facility. So definitely always look at the individual patient results. So Barbara from Massachusetts Department of Public Health wanted me to remind you and clarify. So the first slide, when I started to talk about the definition for CDI lab ID events, that's the only definition you use to report your CDI lab ID events in NHSN. The community acquired long-term care, that's NHSN will take care of that at the back end. It's just to give you an idea of what could be considered community acquired or long-term care acquired CDI lab ID event. So just stick to when you're reporting to the 14-day previous 14-day rule. So even if you have a C. diff positive test on a resident who's been in your facility for 24 hours, that is still supposed to be entered. Everyone knows you didn't create that C. diff. You didn't have time to create that C. diff case. But that is still to be entered into NHSN, and NHSN will categorize that as community onset or coming from the acute care hospital. They won't ding you for it, but they still want all of that data entered. Right. There's a question here on the difference between days of therapy and length of therapy.
Yeah, so Kelsey asked a really great question, and for the sake of time, I didn't really get too deep into length of therapy. So, you know, I talked a little bit about days of therapy, how it looks at how many days and on any given day who is getting which antibiotic. Length of therapy doesn't differentiate between which antibiotic patients are getting, or it doesn't even really need a denominator. That one is really, if you aren't able to access your patient census and you're not able to normalize your data, you can really just look at what is your length of therapy like. What are how long are your average courses of antibiotics? So if you see that there were 20 prescriptions for antibiotics written in any given month, you can just average out what is the duration of each of those prescriptions, and that will bring you to your length of therapy. That helps for certain, identifying if you have a problem with people that are prescribing antibiotics for too long. And it's really useful for facilities that aren't able to identify their census. But in speaking with a lot of you and our experience, figuring out what your census is not a big barrier. So for those reasons, I didn't get too deep into it. Days of therapy and antibiotic starts are a lot more actionable data that you can really make meaningful change off of.
I think one point to make is that you have options within your facility. That even if you have technological or data barriers to some of one or more of the antibiotic usage metrics, you may be able to access other antibiotic usage metrics. So it's really about going through the data that you have and the technology that you have, talking to your consultant pharmacist and figuring out what is doable, and then using it to the best of your ability to drive change. Other questions? Don't hesitate.
Hi, Shira, this is Alazy. I'm just asking if you can pass me the ball. And if anyone has any questions, you can either enter via chat or you can come on the line and ask your question. You just have a couple of minutes. Okay, it looks like we are hearing none, and I will go through the closing slides, and I have some announcements to make. We are excited to announce the advanced series coming in January to all facilities in New England in partnership with the Massachusetts Department of Public Health and the Antimicrobial Stewardship Specialist at Tufts Medical Center. The registration invitation for the upcoming series will go out at the end of October, early November. For the upcoming series, facilities should have viewed the 9-part webinar series prior to participating. As a reminder, Massachusetts facilities who complete the full series by October 31st will receive a certificate of recognition from MDPH and QIO. If you missed a session, not to worry, it's not too late. You can access the archived webinar on our website listed in chat. Certificates will be mailed out the first week in November. If you haven't joined our free virtual learning system, we invite you to visit the Learning Center at learningsforquality.org. The New England QIN-QIO offers education in bite-sized chunks to accommodate your busy schedules while also allowing you to gain continuing education units with many of our courses. Topics such as QAPI, infection prevention training, mobility, pain management, and medication reconciliation. And lastly, this is our state lead's contact. So if you have any questions, please contact the QIO state lead that's listed on this slide. And it looks like we have a question from Jessica. Did Connecticut facility receive any documentation of completion? Yes. So all of the Massachusetts home will receive the completion certification, and if you have any other questions regarding the certification, please contact your state lead, and they will give you more information about that. And let's see, is there any other question that I'm missing? I know we just have one more minute here. The speakers, if you would like to answer the question from Margot.
Yes, of course. So The question is about a patient who's colonized with C. diff and it flares up about once a month with loose stools, and the question is, should you test or just go ahead and treat? And I'll say this sounds like a pretty complex clinical situation, but realistically, given the tools that we have in our armament, having multiply recurrent C. diff, with more than 3, 4 beyond recurrences, really, we'll have some options out there. This new monoclonal antibody. We have stool transplants or fecal microbiota transplants. So there's a lot of options out there to address this. And we wouldn't encourage you to just keep on testing and treating with the same old thing, and really refer out for kind of a little bit more complex care.
I want to add too, I think one of the things I was sort of cringing about is in Gabriela's example of who you should report and not report to NHSN. There was sort of an implication that it was okay to keep sending C. diff that often, and that wasn't the point. The point was that if you send C. diff every week or so, those are going to be counted as duplicates, and you don't need to keep reporting positive C. diff tests that happen within 2 weeks of each other. That doesn't mean that you should be repeatedly sending C. diff every week. And so if a resident is diagnosed with C. diff, then they continue to have loose stools. We've talked about this scenario in the past. First of all, you may want to wonder whether C. diff was actually the diagnosis, because they should be responding, at least initially, to therapy. Recurrent C. diff is a common problem, and so you would, if somebody with a history of C. diff has another episode that clinically appears consistent with C. diff, you do want to send a test, because although it is usually positive, because we know that the PCR stays positive for a long time, if it's negative, that information can be useful. And then if it's positive, you do have to realize that PCR tests stay positive for a long time and make sure that you are accurate and appropriate diagnosis. Many of these patients who have C. diff also have issues with chronic dysbiosis and chronic antibiotic-associated diarrhea. And so if you have a resident who has recurrent bouts of diarrhea and possible C. diff, that may be a situation where you may want to involve an expert like a GI doctor or an infectious disease doctor.
Okay, that looks like it is all for questions. We just want to thank everyone for participating in this 9-part series. We thank you for your time. You know you're valuable, and we hope that you have benefited from this series. If you have any questions, don't hesitate to contact us. Have a great rest of your day, everyone. Thank you.